Everybody, I'm Edward.
Good afternoon.
Here from University of Cape Town. Hi, Christian. Um, that was quite a short notice because pathology couldn't present this week, so we jumped in for them. So we're going to present some cases, or our fellows in HPB surgery are going to present some cases, interesting cases. We're going to start off with the HCC and then some non-HCC cases as well. So, as you know, these sessions are hosted by the Gastro Foundation in association with Project iEcho, run by the University of New Mexico. They every Wednesday. And then the chat will be open for any questions. I'll keep an eye on that. We try to keep it as interactive as possible. And please feel free to ask any questions or post questions in the chat group. So we're going to start with a case that's presented by Dr. Brian Misoi. He's a fellow from Kenya, currently training with us. So Brian, if you're ready to go, we can go.
Thank you, Prof, and thanks for everyone joining us. I'll just share my screen. Okay, so the first case is over 40-year-old female who presented to us. She had no comorbidities with a good baseline. Her performance status was 0, and she was fit. We considered her fit for major abdominal surgery. She presented with acute onset right upper quadrant pain and tenderness. And at the time, her examination was unremarkable, save for the abdominal findings. She had had a preliminary ultrasound report that was done bedside, and this reported a large right hemiliver mass with minimal free fluid in the subhepatic space. Investigations ordered at the time included a full blood count, which showed relatively normal parameters, so a white cell count of 7.9, HB was 9.6, the platelet count of 240. There was a limited liver function test, which showed a total bilirubin of 7, which was normal. ALT and gamma GT are as shown, all normal. She had a hepatitis screen, and the surface antigen came back positive. A subsequent viral load done showed a result that was lower than detectable. And then a hepatitis C antibody was negative, and the HIV screen was negative as well. She had an A3 done at admission, and the result was high at 6,101. So we ordered cross-sectional imaging, and I have 2 windows here. So I'll just take you through the first window, which is an arterial phase axial scan of the abdomen. So I'll just try and scroll through slowly, and starting from the diaphragm coming down, the liver looks normal in contour. However, as you approach segment 4B, you begin to see a hyper-enhancing or hypervascular lesion or observation, abutting the right portal vein. It has areas of hypo-enhancement centrally, and it extends to segment 5. And if you look around it, there's some fat stranding and some free fluid, and that extends into the subhepatic space anterior to the kidney. The rest of the liver, particularly the left hemiliver, seemed normal with no lesion identified. Looking at the image on the right, this was the portovenous phase, and coming down to that observation at segment 4B, there seems to be washout of the contrast centrally, and you may appreciate a capsule, particularly in the lower edges of the lesion or the observation. So with these findings, a large mass in the right hemiliver with arterial phase hyperenhancement, non-dream hyperenhancement, and washout in the portal venous phase. We gave this a Lyrath 5 based on the fact that she has chronic Hep B in viral infection. So our working diagnosis was chronic hepatitis B virus infection with a viral load that was lower than detectable, a non-cirrhotic liver with preserved function, the Child-Pugh score of A5 with large right hemiliver HCC, and we thought that the free fluid around the mass represented a tumor bleed. So I'd just like to pause there and ask the audience what they think about the case, any additional information they would like, and what management options we have.
Now, Brian, I think this very nicely demonstrates the situation we face in sub-Saharan Africa with the disease or hepatitis, chronic hepatitis B infection being a major etiological factor, and seeing the tumors in young people and in non-cirrhotic livers. And it's something that we always have to be, I think, aware of, that in patients with active infection and a high viral load, that one should not forget to treat the HCC before you certainly embark on any curative intended treatment. But we'll come to that. Just in terms of the sequence of drugs that we would use in these patients, I don't know if there's any, Professor Tsoitong, maybe you can help us there, or any of the other hepatologists, on which drugs would we start on if this patient if this patient had a high viral load, and we had to treat it. What would we start with, and how will we continue, and when would we be happy to intervene on what viral count?
Yes, in our case, we used to start tenofovir.
Mm.
It is the main drug we have here, and generally we do that.
Okay, so you would start with tenofovir. And when do you think it's appropriate for us to, if we're going to start treating the tumor, at what viral load would you think that would be appropriate?
Oh, I think that the best thing is to wait that there is no viral load detected again. So the minimum of viral load is preferable. So which is undetectable, we can go for surgery.
Okay. Thank you very much. Yeah, Brian, you want to take us through the management options, or are there any comments from any of the colleagues so far? We can take one of your countrymen here. Karan, I see you on.
Hi, Prof. I'm on, but there's a lot of background noise here. I'm babysitting, so let me just type what I think.
We can't, the baby doesn't bother us. Karan, we can't hear.
Please welcome.
Karen, it's called parenting, eh? Not babysitting, parenting.
Yeah.
Can you tell us?
So, so I think, yeah,
Karan.
fortunately for this patient, there's a low viral load, but with that alpha fetoprotein level being pretty high, I mean, at a glance on the imaging, it looks like perhaps it would be something that could be upfront resectable, especially with the non-cirrhotic liver and no features of portal hypertension. But there was some abutment of the right portal vein, I think that Brian mentioned. I think this is something that perhaps you would consider maybe some form of therapy to shrink it a little bit, like a transarterial chemoembolization, and then embark on surgery later. Fortunately, the viral load is undetectable, so we don't need to treat the Hep B. But that's what I would think maybe we could do in terms of surgical options. It is limited to segment 4 and 5, so perhaps one could even just consider a parenchymal sparing operation, or maybe do a central hepatectomy.
If you look at it there, I think it's a little bit into at least 6 there as well. just if we pause for a moment, Dr. Malu asked that this patient has got a detectable, doesn't have a detectable viral load, but would one still give the patient tenofovir at this stage? Professor Tsoito?
I think as we are not sure there is no virus at all, I think it's better to maintain tenofovir.
Was this patient treated, Brian, or has she cleared the virus?
So she was started on Truvada, but this was the first viral load at diagnosis. So,
Okay, that was not detectable. So she's basically cleared some of the virus at least.
yeah.
Okay. All right, so Karan proposed surgery. You can take us further, Brian, and what the issues were.
So we thought that the lesion would be resectable upfront. However, the only concerns were that we may end up with extended right hepatectomy. However, the segment segment 8 and 7 seem to be preserved or spared from the tumor. The fact that we were thinking of an extended right hemihepatectomy, we calculated the future liver remnant, and using the standard liver volume, that came to about 20%. So that was part of our considerations when treating this patient. So segment 1 to 3 came to about 20%. So then what we did was, in consultation with our hepatology team, started the patient on Truvada, a combination of tenofovir and lamivudine. We offered the patient TACE, firstly because she had bled. We thought we'd get that under control, and also test the tumor biology because our AFP was elevated. And at the second visit, she had a partial response in terms of her biochemistry. And we reviewed the images, and in discussion regarding the resectability, we thought we should augment the future liver remnant, which we thought would be segment 1, 2, and 3. And so we offered her right portal vein embolization and right hepatic vein deprivation. And at the same setting, we topped up the TACE. And then we reassessed her in terms of tumor response, so and the response to the augmentation with a CT and a new AFP. The AFP came back to 115, came down to 115 from 6,101. And the new CT, I will show in the next few images. So firstly, I'd just like to demonstrate the outcome of the TACE and just the pictures from the portal vein embolization. So the first image, top left corner, shows the initial runs during the transarterial therapy. And you can see the hepatic artery has been accessed and blush or tumor taking up contrast as demonstrated. So the next image on the right shows the tumor post-embolization, where you can see the arterial inflow into the tumor has been cut off after embolization, after infusion of the chemotherapeutic agent and embolization of the feeder vessels into the tumor. So that was a good effect from the TACE radiologically. And then the bottom left image shows the portal vein has been accessed percutaneously with opacification of the right trunk. This patient had aberrant anatomy. So the next image on the bottom right shows embolization of inflow into the right hemiliver. So the image shows embolic material being injected into the aberrant vessel that's coming off of the left portal vein, but the main trunk to the right was also embolized. This was to ensure that there's no collateral flow into the right, and thus limiting the response to the augmentation. Then this next image just shows the hepatic vein deprivation, and the plugs were placed through a sheath that was introduced transjugular into the right hepatic vein. And you can see the big plugs blocking the vein, and then the plaques that are cast in the right portal vein are also visualized in the background.
Right, I think if we can just pause there for a second. Obviously, the getting the viral, the AFP down is important for us, because if the AFP had remained very, very high, we would have been worried about metastatic disease, and that maybe surgery wouldn't, or planned surgery wouldn't benefit the patient. But the other question is this is a very aggressive way of treating, because if you think about portal vein embolization, TACE is basically, or one of the relative contraindications. Some people would say an absolute contraindication is a patient with a portal vein thrombosis. And what we now do is we do a TACE. In other words, we thrombose the artery, as a TACE does, and then afterwards we go and we basically take away all portal flow in the same part of the liver, and on top of that we block the right hepatic vein, deprive that of any blood flow. We can maybe ask Sanju. Sanju, would you be that aggressive in Johannesburg?
I don't know if I would be aggressive at anything here, but I think that the fact that the patient is non-cirrhotic is also something really different. I think we talk about TACE in people who are generally cirrhotic, who don't have very good hepatic reserve. And there's always a concern that, you know, if you're going to close off the portal flow or the hepatic venous flow, outflow, it's going to be an issue. But that's not really the case in our population, is it? It's young people generally with excellent hepatic reserve who can tolerate a number of maneuvers.
Now, I'm more thinking about in terms of making that part of the liver completely ischemic, because we basically knock out the artery, maybe a little bit selective here, but and then also take out the all flow in the portal vein, and then for the little bit of blood that would still get into that liver one way or the other, we block the outflow.
Yeah, I just wonder whether the other option would have been to do it in a staged fashion. Do the TACE first, wait, and then go afterwards and do the PVE and the right hepatic vein deprivation. I wonder if that would have been maybe a safer approach. I mean, this is now a 3-in-1, isn't it? We've done a TACE, super aggressive, done a PVE, and done a right hepatic vein deprivation. And I agree with you. I don't think many people will be doing this around the world.
Yeah.
I mean, certainly in Toronto, they would not do this. I can tell you, the patient will probably get a tear. When I left it, they had just started, or TACE, and then they would wait and try and do some other maneuvers. But Prof, again, I think the other big discussion is, like a lot of centers would say, would we consider this for a transplant? I mean, it is a non-cirrhotic patient, right? That's the other thing that really sets us outside of all these guidelines. This is not TIC.
Yeah, you know, we sometimes a little bit pressed for time, and especially with patients with large tumors, if you're going to stagger this and it goes over time, that you lose the opportunity. So I think we've done 3 or 4 of patients with this very aggressive method. We'll see what this one showed, but we haven't really run into problems with necrosis that was a problem before the eventual surgery. Another question is, if you don't go to surgery, what happens to it? But we don't have an answer for that question. I think
Anybody could have considered a tear. Everybody is raving about it now. There's a bit of portal vein involvement, whether it's abutment or infiltration, one is not really sure. Would somebody have done a tear in the lot here?
I don't know if there's anybody here that's got access to tear. We certainly don't.
Yeah.
Okay, Brian.
Okay, Prof. So to see the treatment effect after these maneuvers, we requested a new image. This is just a portovenous phase now. So you can see the plugs in the peripheral circulation on the right hemiliver. And then you see the big plug in the right hepatic vein. You can already see the left hemiliver is now significantly hypertrophied, and the right has significantly atrophied. And now what is interesting is the tumor is now largely necrotic. Appears quite cystic in this new scan. So one of the discussions we had was, given the response that we have, which is near complete response based on this imaging, are there situations where you'd consider follow-up rather than going for surgery, although that's not what we offer the patient, but just a thought for the audience. This shows the trend of the AFP. So it started at 6,000. Post the first test came to about 1,000. And then the second test, together with the augmentation maneuvers, came down to 115. And then we took the patient to surgery, and that came down further. So she had an extended right hemihepatectomy. Part of segment 8 was preserved because it wasn't involved in the tumor. But in all rights, it was a formal right hepatectomy to include segment 4B. This shows the final histology, and they couldn't assess the grade of the tumor, which would have been nice to know. But because of marked tumoral necrosis, there was not enough tissue to look at that. And then the greatest dimension of viable tumor was now down to less than a centimeter. And if you look at the extent of tumor necrosis, that was more than 90%. And so the final staging was a T1B N0. There's some nodes at the hepatoduodenal ligament that was assessed, that came back negative. So I'll stop there and see if there's any comments or questions from the audience.
So Brian, I can't see any questions or comments. I think quite a good result. Obviously, we will have to see what happens with the follow-up. We can maybe, just in the interest of time, continue with the rest of your presentation and then move over to Malini's.
So the question really is, can we improve our selection for patients for neoadjuvant treatment in resectable HCC? We know that TACE is well established for intermediate stage HCC based on the Barcelona classification. And we know that it's considered a non-curative option, but it does offer prolonged survival in patients who are where it's indicated. We know that we can use it in situations where we want to downstage tumors or to bridge to transplant. But no guidelines really talk about using TACE as neoadjuvant therapy in patients who have resectable cancers. And most would say if the cancer is resectable, then proceed to resection. But we know that patients present in a spectrum in terms of the liver function, the general physiologic state in terms of fitness to withstand major abdominal surgery, and also tumor resectability, together with the biology, that is the AFP, and concerns for occult metastasis that's not obviously detectable. So we also know that there's some evidence for adjuvant TACE after resection, after curative resection, and some meta-analysis have shown there's improved recurrence-free survival and overall survival. So what would be the pros for using TACE as a neoadjuvant strategy? we can assess tumor biology. We know that well-differentiated HCC is more likely to respond to TACE, and therefore, because we're not going to biopsy the tumor, and the tumor also is heterogeneous, so a biopsy may not be representative of the whole tumor. So if we see a good response, then we can infer that there's good biology. Second thing is it's a good option to downstage tumors, and we know from liver transplant specimens that there's 75% response in selective TACE. It can also provide time to optimize patients or to augment the future liver remnant. The cons, however, are that in the patients who we are thinking to offer neoadjuvant therapy in terms of TACE, these are the ones who have the tumor characteristics that are less likely to respond to TACE. So large tumors or multifocal tumors and tumors with vascular infiltration. And the other thing is that the hepatocellular carcinomas themselves have heterogeneity, and this really compounds prediction of response to TACE. So in the tumor itself and in the general population, the tumors respond differently and have different tumor microenvironments. So we cannot predict accurately who will respond better. And then we know that patients can suffer post-TACE complications, and this may either delay surgery or affect the tissue planes and make it difficult, or some patients may drop out and not get to surgery. So then the question should be, who should we consider for neoadjuvant TACE? And should we maybe introduce or try and get access to different transarterial therapies like TARE, and maybe select patients better for this? I'll leave my presentation at that point.
Thank you very much, Brian. Very nice presentation. Are there any comments or questions from the participants, any of the participants? I don't see any in the chat. Okay.
Prof, if I may just comment, I think it's a fantastic response. Difficult in our setting elsewhere to convince an interventional radiologist to do every single vessel to the liver or from the liver to embolize everything. Like you said, there's always that worry or the risk that we would induce ischemia in that liver, can get abscesses, certain things like that later on. Do you think this is something that should be published? Should we look into this thing in more detail in terms of how doing arterial plus venous embolization may not necessarily induce ischemia in the liver, and because this really expands our options in terms of what we can offer, especially where volume is a concern. And as Sanju has said, should this be done only in non-cirrhotic livers, or should we consider doing this in cirrhotic patients as well?
Yeah. I think the reason why we started this, is we've had some patients where there was progression and then they became inoperable. Now, obviously, you shouldn't do something that is dangerous for the patient and can shorten a potentially short life even more. So I think one has to do it carefully. We've done it in mostly in very young patients with normal liver function, non-cirrhotics. And I think it's a proof of concept that maybe when we get to 5 patients, one should write something about it. I recall many years ago in Kenya, in Kenyatta Hospital, that when the EHPBA did, when they started the chapter there, I went there with Martin Smith and we operated a few patients. And there was a patient with a HCC that we operated eventually that was explored by the colleagues there, and they basically bailed. But what they did is they tied off the right portal vein and the right hepatic artery. And that patient just had a big, massive cystic tumor in the liver and in the right liver. And you saw the same hypertrophy that we saw now in this one, in that patient, and we could do a resection. So it's certainly something that maybe out of lack of other modalities has been done before, is to devascularize the whole liver. But there certainly is a a risk that that there can be necrosis, then one will have to deal with that. But I think, you know, once we get to 5, we can maybe revisit and just see how it went. But so far, it went well for these patients. Any other comments? Okay, I'll switch off my microphone. Thank you very much, Brian.
Thanks,
And
Prof.
yeah, and Malini can start sharing and give us her presentation. Malini, I think you may be muted.
Okay, so my topic is not HCC. I'm going to talk about biliary precursor lesions, and I'll start with a case presentation. So we had a 59-year-old male that presented to our hospital with abdominal pain. No significant comorbidities. In terms of his bloods, he had slightly raised liver enzymes, ALT, AST, and GGT, all below 100 though, and normal bilirubins of 7. So not jaundiced. And he was also newly diagnosed hepatitis B. This patient went on to have a CT scan, you can see here. So if you look at this axial scan, you can see there's some intrahepatic biliary dilatation. Also some calcifications on the left side there, segment 4B5. The right side also has some dilated ducts, and that ends quite high up. The distal CBD is normal. Pancreatic duct is a bit prominent, but normal otherwise. It's also quite marked atrophy, if you can see on the left side of the liver here, with crowding of the ducts in that area. So this patient went on to have a MRI or MRCP, which didn't really show anything more than the CT scan. And so the next step then was a ERCP. And at the ERCP, I'm just going to show you what we found. Okay, so at the ERCP, you could see this mucin-like substance that came out from the papilla. We went on to do brushings of the right and left hepatic ducts at this point. And that was all that was done at this point. So I'll just pause there and ask anyone to comment on what they think possible differentials would be at this point.
Let's see if we've got that we know. Rashid was on. Rashid. Don't know if Rashid is on from Windhoek. I don't think so.
Okay,
Maybe.
just go on there. So things that we considered at this point was a cholangiocarcinoma, liver flukes, which can also look like that. These biliary flukes that can come out of the ampulla, polydocal cysts, and biliary precursor lesions, bilins and IPNBs. So the histology of the brushings that we did came back as all negative for malignancy. And this patient went on to have a left hepatectomy and a cholecystectomy. Intraoperatively, we did a frozen section of the bile duct at the left duct where it was transected, and that was negative for malignancy. This is just the mucin that was coming out at the ERCP. And the histology from the hepatectomy came back as an intraductal papillary neoplasm of the bile duct with high-grade dysplasia. No invasive carcinoma was identified. Just of interest, the MCNS from the bowel that was suctioned came back as Burkholderia species, which is quite a rare contaminant for biliary sepsis. Okay, so if we look at biliary precursor lesions and how they're classified, they largely arise from your intrahepatic and hilar cholangiocarcinomas. Extrahepatic can give rise to these, but less likely than intrahepatic and hilars. And they can be divided into two types based on the cell of origin, which is either small duct or large duct cells. So the small ducts give rise to non-mucin producing columnar cells, and the large ducts are from your mucin producing columnar epithelium. And the two types of precursor lesions that we have is Billens, which is your biliary intraepithelial neoplasias, and IPNB, which is intraductal biliary neoplasm of the biliary tract. So these lesions are thought to be the biliary counterparts of the pancreatic lesions, which is our Pannans and IPNM. And the reason is because in the pathology specimens of these lesions, you can actually find pancreatic exocrine acini intermixed with the biliary epithelium. And the fact that they both give rise to similar invasive carcinomas. So your Billens, just like the Pannans, give rise to conventional adenocarcinoma. And your IPNB, just like IPNM, gives rise to a tubular colloid type of an adenocarcinoma. So if you look at the classification of these tumors in the WHO, this is what they are classified as, either with low-grade dysplasia, high-grade dysplasia, or if they demonstrate an associated invasive component. So the difference between the two starts at a microscopic level. So your Billen lesions are microscopic, just like the Pannans. They can be divided into a low-grade or high-grade, and they are associated with KRAS and TP53 mutations. The IPNB, on the other hand, are macroscopic premalignancies and is thought to be multicentric proliferation of your columnar epithelium. So they can arise, as I said, in the intrahepatic or extrahepatic large bowel ducts, but are more commonly associated with the intrahepatic bowel ducts. Males are slightly more affected than females, and it's more middle-aged or older adults affected. This is just an example of what the lesion looks like. There's some sludge over-covering a somewhat elevated lesion of the mucosa under this, and this is an IPNB. So in terms of carcinogenesis and how they then go on to be invasive, both Billens and IPNBs, as I said, can give rise to tubular adenocarcinoma in a similar method as colonic tumors with dysplasia, metaplasia, and then adeno-CA. The risk factors are similar to that of cholangiocarcinoma, so anything causing chronic inflammation, PSC, but they do have a specific predilection for hepatolithiasis and liver flukes, and they are more commonly seen in the Asian countries where this is endemic, like Japan and Korea. If we look at the classification of our Billens, as I said, you can get a low grade, a high grade, and a carcinoma in situ, which are labeled as Billen 1, 2, and 3. And this may seem like an easy differentiation to make, but it's actually very difficult histologically to make this differentiation because these precursor lesions look very similar to reactive atypia. So anything that causes inflammation could cause a lesion looking similar to these three. And the only differentiating factor is that in the surrounding stroma, there will be inflammation, which shouldn't be present in a biliary precursor lesion. In terms of IPNB, we classify them into types also based on histology, which is the pancreatic or biliary, intestinal, gastric, and oncocytic, similar to IPMN. The pancreatic or biliary subtype is the commonest and also has the worst prognosis in IPNB. In terms of the clinical presentation, IPNB, because it's a mass lesion, these are more likely to present with something like jaundice or abdominal pain, whereas your Billens, being microscopic, are less likely to be symptomatic, and the majority are really incidental findings, or they're found on surgical margins post-resection of a cholangiocarcinoma. Another possible presentation is rare, which is hemophilia, and they're just case reports of this described. Okay, then just in terms of discussion points of it, the prognosis of these lesions, is it the same as a cholangiocarcinoma, which they ultimately progress to, or any different? There's very little evidence on this, but what I could find were a few cohorts and series. This one was one from Asia where they looked at 58 patients with IP and B, and they found that the 5-year prognosis was really quite good. So the survival rate at 5 years was 81%, but a big problem in these patients was recurrence of disease. So almost 20% of these patients had recurrence somewhere in the biliary tree. And the suspected method of this is intraductal dissemination, because these are intraductal tumors or masses that occur. And all of the recurrence was in an associated side of the biliary tract. Another review looked at, this was from Japan, looked at 22 patients with IPNB. So there was 9% of these had low-grade dysplasia, 36 high-grade, and 55% an invasive component. And there was quite good survival rates for all of them, 100% survival at 10 years for the low-grade and the high-grade, but slightly lower for the invasive component at 69%. So quite a good prognosis, but high rates of recurrence. In terms of its significance, if you find it present at a resection margin when doing a resection for cholangioCA, this was a study looking at over 300 patients who had resections for a perihilar cholangioCA and were found to have bilin. So of these, 18 were found to have high-grade biliary intraepithelial neoplasia at the resection margin, and the survival and recurrence was actually the same for those who had it at the margin and those who didn't, suggesting that no additional resection is required if it's just high-grade dysplasia. It's only if it's an invasive component that then it needs resection. In terms of adjuvant therapy, there's really not much evidence on this at all. I could just find case reports of patients who received adjuvant therapy for this, and there really are no guidelines for this. So in conclusion, cholangiocarcinomas, as we know, present with advanced disease and have poor outcomes, which makes these precursor lesions potentially important to improve outcomes. Surgical resection is the mainstay of the treatment, and it's really uncertain what the prognosis is of these patients, and there are no real treatment guidelines or follow-up guidelines. But regular follow-up for IPNB is probably very important because of high rates of recurrence. Okay, thank you.
Thank you very much, Malini. So it is something that I think only recently has come into the scope of certainly HPB surgery. I think one saw these lesions before, but they didn't have a name. So do you think this is something that we only recognize now, or pay attention to, or that there's an increasing incidence that made it appear more common?
Yeah, I don't know that there's an increased incident. I don't think we were looking for it before, and it's only now that we're recognizing it. Yeah.
And because if you look at the publications out there, I think there was an IHPBA collective study where people could report it in, and I'm not quite sure what numbers they got out of that, but most of the publications are double digits. It's not even into the hundreds yet. So it's not that common. Just one thing
Most
I want.
of the evidence that I could find was from Asian countries, because they really are the only ones who have slightly higher rates of this, who have looked at it in terms of outcomes.
If my memory serves me correct, this patient was actually subsequently diagnosed with PSC. That may have been sort of the underlying pathology that precipitated this. Just this one question: what's the role of spyglass in this?
So I think spyglass would be important for IP and B to pick up the macroscopic lesions, but the problem is they don't always present with macroscopic lesions. So although it commonly does, IP and B more commonly presents macroscopically more than bilin, they don't always necessarily have a macroscopic lesion. So it doesn't exclude it, But if there is one, then it would be great to see it and pick it up.
But the problem is the Bhanans you can miss completely.
Yeah, balance you won't see at all.
Yeah, as one does in the pancreas. Any other questions or comments? Sean, from your side?
Thanks, Sid. Yeah, I mean, it's a really interesting case. I mean, I think at the moment there are obviously parallels being drawn between the IPMNBs and the IPMNs of the pancreas, and whether that's fair to do or not, I think we don't really know because there isn't really enough data. I think what's interesting to think about is, you know, there's obviously still quite a lot of debate around the IPMNs of the pancreas and which ones and what exactly are the criteria for resection. So if one asks the corollary, you know, is there a role potentially for conservative management of the IPMNBs under certain circumstances, and what would you use as, you know, to draw an analogy, what would you use as high risk stigmata and worrisome features to draw parallels with how we manage the pancreas? And I suppose it just isn't really the data around that, but I think it's perhaps an interesting question to ask. I think the only other thing I would maybe mention from an academic standpoint. So I think, you know, a fluid analysis from IPMNs from cysts and potentially from the duct, you know, has had relatively little value to now, but I think with molecular biomarkers and mutational analysis, that's becoming a little bit different now, and the markers are getting better for those lesions that one should worry about. And one wonders if a similar thing is not possible with the biliary lesions. But I think that's very much an academic question, a research question, and probably less relevant to our environment.
I think one of the problems to have a same system where you can look at duct diameter and things is the pancreas got one duct that we look at, one main duct, and the liver is sort of a little bit more complex. Just one thing, Malini, you mentioned that they found acinar cells in some of these changes.
Yes, so in the specimens, they found pancreatic exocrine acinar cells mixed with the peribiliary glands, which is another reason they link the two to the pancreatic counterparts.
Yeah. No, that's really interesting. Any other questions or comments? We're a little bit earlier today, but sometimes we go over, so we can stop a bit earlier. So if no more comments, thank you very much to the speakers and for all the attendees, and also thanks to the iEcho team in America and also in India. These recordings are all available on the Gastro Foundation website, and thanks to the Gastro Foundation for hosting this. And then next week, if I'm correct, Cheryl, correct me if I'm wrong, but I think it's upper GI endoscopy.
That's correct.
I hope we see you then. Thank you very much.